Recording in progress. Recording privileges. It'll take us a couple of minutes and then we'll get started. Thanks for joining us. Again, good morning, everyone. For those of you who are just joining us, we're going through and giving everybody recording privileges. It takes us a couple of minutes. We'll start in just a minute or two.
Good on my end.
Good on my end.
Great. Thanks, Ryan. Thanks, Joanna. Thank you all very much for joining us today. I'm Cassie Sauer. I'm the CEO of the Washington State Hospital Association. And joining me today is Dr. Linda Eckert, who is a leader of obstetrics at Harborview and a professor of obstetrics at the University of Washington. We think the issue of how this disease is affecting pregnant women is one that continues to deserve really serious attention. So we're very pleased Dr. Eckert could join us. We have Julie Peterson, who's the CEO of Kittitas Valley Healthcare in Ellensburg, who can talk about what's happening in rural communities around the state. And finally, Peg Curry, who is a nurse and is the Chief Operating Officer of Providence Sacred Heart in Spokane and a member of the board of the Washington State Hospital Association. So thank you three very much for joining us. I'll start with some opening comments, and they continue to be bad. I actually hate my opening comments more and more at these press briefings. I don't think all the data's in because it was a holiday weekend and I think there was some reporting lag. It looks like that's the case across the country. But even with a reporting lag, this morning, there were 1,674 patients hospitalized with COVID-19 across the state. That's an increase of 7% from last week, from when we last reported the numbers to you. Even more shocking is there are now 251 patients on ventilators. That's a 34% increase from last week. And to be clear, a lot of these people are not going to make it. Hospitals are providing incredible care to them. It is hugely labor intensive, but folks, once they get on a ventilator, many of them will not survive. It turns into a cascade of organ failure and other very serious issues. And so that number, some percentage of that number is going to turn into people who die. And those who don't are going to be very sick for a long time. It's really hard to come off a ventilator and to be, you don't just go come off a ventilator and go back to work the next day. These are folks that are going to be struggling with the after effects for a long time to come. It looks like there's about 20 deaths in the last reporting period. Again, those numbers I think in particular are a little, there's a lag in the reporting from the holiday weekend because a lot of that comes from some public officials that may not have been working yesterday. So really much higher numbers. These continue to be almost exclusively unvaccinated people. There are some folks who are vaccinated who are sick in the hospital. By and large, they are people who that are immune compromised. They've had an organ transplant. They've had serious cancer treatment recently. They have been affected by being exposed, most likely to someone who is unvaccinated who got them sick. But the vast, vast majority of patients that we're seeing in our hospitals are unvaccinated. And as we've said before, really requesting all the treatment they can get once they get to the hospital, including a lot of experimental treatment. So we want to continue to encourage people to prevent having to go to the hospital in the first place, which is get your vaccination. The second thing I want to note, I just want to reflect on something that one of our panelists said last week that really kind of haunted me over the week and just got very much in my mind that we sort of glossed right by, and I really wanted to highlight it. So we asked for examples of the kinds of procedures that are being canceled in order to make room for COVID patients. And I think that's a really important thing for people to know is that not getting vaccinated, using a very staff-intensive hospital room means that other people are not getting the care that they need. So one of the examples that was given was a colostomy reversal. If you don't know what a colostomy is, we were happy to answer that question, but I think probably most of you do. So someone might have had, for example, an abdominal cancer that they had surgery for, a colostomy was involved in that, and they can be reversed once the patient recovers and stabilizes. So I just want you to imagine for a minute, if you had a colostomy and you thought it was going to get reversed, and you found someone called you on Friday and said, we are canceling your colostomy reversal surgery that's scheduled for Monday, and we don't know when we can do it. The mental health impacts of that, it's not life-threatening, but the mental health impacts of that are just, and the life impacts, the lifestyle impacts of that are just profound. And so I think we keep talking about the cancellation of non-urgent procedures. That is a really good example of something that is terrible for the patient who has had to suffer that cancellation. And we know that's happening all around the state. And we can hear other examples from the folks that are on the call about the kind of care that people are not getting. People hear cancellation of non-urgent procedures and they think facelifts. That is not what we're talking about here. We're talking about very serious care that people need. The third thing I wanted to talk about is the monoclonal antibody treatment. There is, I think this was not really widely covered. The federal government approved administration of monoclonal antibodies via a subcutaneous route rather than an infusion route. And so that opens up the possibilities. It's basically a series of 4 shots. And Peg, our nurse, or Dr. Eckert, our physician, could definitely speak more about this, but it's easier to do and allows for more treatment centers in order to do it. And so we are working with the state, really urging an expansion of the kinds of providers that can give monoclonal antibodies, pharmacies, clinics, ambulatory surgery centers, outpatient facilities. So it's not so reliant on hospital ERs. We're having a lot of people arrive at hospital ERs, and maybe Peg, you can speak to this, seeking monoclonal antibodies, and we would like that treatment to be happening someplace else since the hospitals are so full. And we also would like to keep COVID patients who don't need hospitalization out of the hospital, so they're not potentially spreading COVID within the hospital. And then finally, the last thing I want to say is that we continue to work on difficult to discharge patients, working with the state. Very pleased with a lot of the work that they've done to move patients who are on Medicaid or who are Department of Social and Health Services, Home and Community Services patients out of the hospital. We think there needs to be continued work on this, potentially opening some alternative care sites, use of COVID positive nursing home units. The state had some of those in place the last time around. They're working on getting those restarted. The state has put in place some financial incentives to help move patients. Those incentives we would like to see continued, potentially even expanded. So we're very grateful for what's been done so far, but we need the hospital beds that are being occupied. About 10% of hospital beds across the state are occupied by people who have no medical need. That's a lot of capacity, and we need that capacity for people who have acute care needs. So really hope that that work will continue and accelerate. I think the very last thing I would say is we want to just really applaud our governor for several public officials, our governor for requiring masks in schools. As we've said before, the fact that this is a debate elsewhere is remarkable. I think it is really smart as we're starting the school year to have kids in masks. I'm really glad that my kids who are in school are in schools that where other kids have to be masked. And we want to also note that there are more and more local officials that are going to be requiring proof of vaccination for non-essential public gatherings. The King County Executive, for example, this morning just announced that they are working on proof of vaccination for things like sports events, concerts, et cetera, trying to make those public gatherings safer. So we appreciate that work as well. And I think that's happened I believe it's happened in Clallam and Jefferson counties as well. That would be worth to check that those 2 counties have done it, but I think something like that. So with that, I'd love to turn it over to our panelists. So Peg, I'd love to start with you with a statewide view, since Providence is operating in so many communities. I know you're on the leadership team, so hear how this is being impacted across the whole state. Thank you.
Well, thank you, Cassie. It's really been an unprecedented time on this war against this COVID-19 virus and now the Delta variant. Hospitalizations are significantly up in Providence statewide. Our experience here in Eastern Washington, just today, we have 305 patients in the Spokane metro area that are hospitalized for COVID. And as you think about a day in the life of what's happening in our hospitals, I'd like to share my experience with you from last week. I was rounding in the ICUs and the CICUs just to take a look with my own eyes again, of course, support the staff who are very, very busy. But the patients there, I can't describe it using any other word besides misery. If people think that COVID-19 isn't going to make them that sick, take a day in the life with me and do rounds up there. There are people up there on oxygen, leaned over, gasping for breath that aren't on ventilators yet. and every breath exhausts them. This is a terrible disease. This is a real disease. And when you see what our healthcare workers have to do day in and day out, it's very challenging. We're well into 18 months of this. And healthcare is not an unlimited resource. Staffing has become problematic across the state, not only for Providence and Swedish hospitals, but for all of us, because our caregivers are getting tired, some are retiring, some are having some breakthrough illness, and some haven't had their vaccination yet. So we're asking a lot of them day in and day out, and they're weary, and we really need to support them. They have care and concern for the community. The other things I wanted to share with you is, yes, we've stopped elective surgeries. And what does that mean for here? Well, we have a children's hospital at Sacred Heart, and I know there's Seattle Children's across the state that had their first pediatric death last week. And this is becoming a children's disease now too. We have to be very concerned. But some of our kids aren't able to have surgery either, that have normal issues that affect normal life for them. Think about having delays in treatments because you don't want your immunosuppressed kid in a place where they might be exposed to other people, or to have their surgeries done, as Cassie remarked. A lot of general surgeries are not happening, and those are things that are delaying things, just like a normal appendectomy. Some of those get delayed because we're unable to staff them, or we don't have the appropriate outpatient beds because we're using them for COVID or other more serious illness across our hospitals. So very, very serious, and not just in hospitals, but our communities. Cassie mentioned the monoclonal antibodies, and of which Providence and Swedish and many others have started to administer not only subcutaneously, but through IV infusions across the state. And remember, these are under emergency use authorization, which doesn't mean that the FDA has approved them permanently like they have the Pfizer vaccine, but temporarily to hopefully avert heavier symptoms by COVID and hopefully reduce the number of hospitalizations. It's not something that's going to answer this whole epidemic, but it's something that might help us through this current surge. It's very scary, and we're starting to administer this to our shelter communities as well. So the spread is contained with our homeless population currently. Lastly, Cassie, I'll mention that our border community, Coeur d'Alene, Idaho, Kootenai Health is a wonderful healthcare center on the border state there, and they have, as of this morning, declared crisis standards of care. They have over 200 national support personnel coming in to help them. Their hospital is 50% full of COVID positive patients. They had 108 patients there this morning, and they overflowed patients into classrooms and other spaces in the hospital. They haven't set up a tent yet, but this is really, really serious. And most of the people we're seeing now are 40s and 50-year-old patients. So this isn't about a disease of the elderly only. It's not a disease of the immunosuppressed only. This is attacking our 40 and 50-year-old community members. Cassie, back to you.
Thank you, Peg. And I just want to highlight something Peg just said, which is that 50% of the hospital in Coeur d'Alene is full of COVID. And that is a remarkable number. Have you ever seen, Peg, a hospital that is half full of one diagnosis?
No, I haven't. And I think that a great segue here is how are our critical access hospitals functioning with this, because their volumes are peaking as well with the number of COVID patients that we're seeing. Stevens County today has 14. And when you think about only having 25 beds or less in critical access, imagine what the emergency rooms are like, the waiting lists are like to try to get into a higher level of acute care. I just, all of us are in this together. But again, whether you're critical access or whether you're a big health system, healthcare is not an unlimited resource. We have to be here for the good of all, not just ourselves.
Thank you, Peg. I think that's a really good segue to Julie. So Julie, I'd love to hear from the critical access standpoint. What are you seeing? What are you and other rural hospitals across the state seeing?
Yeah, thank you very much. So Kittitas Valley Hospital is in Ellensburg, Washington. We're about 120 miles east on I-90 from Seattle, and we're the only hospital in the county. This morning, our hospital is full. And full is defined by staffing. And I think that's true regardless to Peg's point of whether you're a critical access hospital or a major system. This is not a crisis of stuff or of beds, it's a crisis of staffing. Like many rural communities in Washington state, our vaccination rate is not where we would want it to be. We're at about 50%. And frankly, we're not seeing a lot of movement in that at this point. But in rural communities, since the beginning of the pandemic, we've really had to rely on our partnerships in our towns and our counties. We've leveraged those partnerships with all of our resources, including our personnel resources. In Kittitas County, we have a very strong emergency response team, and we have a particularly strong relationship with public health. At the beginning of the pandemic, so more than 600 days ago, we stood up a testing site here on campus. It has been open 7 days a week since it first opened. It's don't need an appointment, you don't need an order, anyone from our county, and we've had people from outside the county who come here for testing. Anyone who wants a test can come in and get a PCR test with no out-of-pocket costs. To date, we've done about 45,000 PCR tests in Kittitas County at that site. Through our partnerships and our mass vaccination efforts, we were able to deliver about 35,000 doses of vaccine in Kittitas County. Sometimes this meant that our EMS units, so our ambulances, were going out to homebound folks to give vaccine, and our sheriff's staff was out bringing folks in during snowstorms. So it was really an all hands on deck effort, and we got the bulk of that done by the end of June. Now we're planning with those same partners for what our booster clinics are going to look like this fall and going into next winter. But like every other hospital in the state, we are experiencing unprecedented volumes. So going into the Labor Day weekend, we were already full. We are a critical access hospital. We have 25 beds available. We have a 6-bed critical care unit with 5 COVID patients in it today. And as I mentioned before, the limiting factor for additional admissions to our hospital is our staff. We are short-staffed, and not just for emergency department nurses and CCU nurses, but we are seeing shortages across the spectrum in environmental services, in dietary, nurses, techs, physicians, short-staffed and exhausted. It is worth noting that at KVH, several of the patients that we currently have here were transferred to us from outside of the county. So rural hospitals are networking, calling one another, looking for capacity, looking for beds, and we're accepting those patients whenever we can. We also get calls from the WMCC at the University of Washington, and we accept transfers from larger rural referral centers, which was never the case in the past. And we're able to take some of their lower acuity patients. But to Peg's point, we have drilled and worked over the years to reduce the time that it takes us to transfer a STEMI patient or a cardiac patient so that we get them to a higher level of care and the best possible outcomes. And for all of that drilling and all the practice that we've done, that has totally gone out the window. Because if you come in with a stroke, if you come in with a cardiac event, there is not a bed out there for you. And if there's a bed, you might be waiting for an ambulance. So this is not just a COVID emergency. This is an emergency for rural residents who've come to rely on our ability to treat and transfer patients to a higher level of care. So going into the weekend, we were already very, very busy and stretched. And over the weekend, Kittitas County welcomed thousands and thousands of people for the Ellensburg Rodeo, for the fair, for the parade, and for a big logging show. And just up the road on I-90, there was a big concert at the Gorge. So later today, our public health department is going to be issuing a notice encouraging anyone who attended any of these events to please come in and get tested in the next few days. So we're going to be staffing up the testing clinic. And again, it's a great service that we can reach out and provide to the community. But these are people who attended very public events. And I don't believe there was a lot of masking going on. And again, our vaccination rate is less than 50%. K through 12 begins in person this week, and Central Washington University is welcoming students back for in-person education again on campus this week. In addition, we learned this morning that there's a new outbreak in one of our nursing homes involving both residents and staff. And we also heard from the jail that there are up to 7 or 8 inmates and staff now that have turned positive over the weekend as well. So not a lot of good news from rural. You know, we are doing everything we can to stretch the resources that we have to be out in our community, be in our hospitals, but staff is just completely exhausted at this point. So we'll be here doing what we can, taking care of everyone who shows up. But we would certainly like to see better use of masking, and we'd like to get our rural residents vaccinated. Thanks.
So Julie, can you just make sure everyone understands what it means if the care for someone who's had a stroke or a heart attack is delayed, and why you work so hard to drill the times, and then what it means when that is not able to be met?
So on a very regular basis, we report tuition. This is a rural hospital thing. There are standards that we try to meet in terms of medications, getting patients to CTs, when they come in with possible strokes, or when they're on an ambulance and we think it's a cardiac event. So we have these protocols in place that we statewide have drilled so that we have a helicopter on the way or an ambulance on the way and all the treatment that can possibly get to the patient, so that we're saving heart muscle and we're saving brain tissue. And we have had remarkable success over the years in getting someone on a helicopter and hearing the next day that they're all but back to normal. And now, again, there's no beds. So we are dialing and dialing, looking for a place to put this patient, doing everything we can for them. But all those protocols, the outcomes are, you know, the classic stroke outcomes where they didn't get the treatment that they needed, or we weren't able to get someone to a cath lab on time. And that was something you didn't see 2 years ago. We had gotten very good at it. And there are simply not beds, there are simply not staff available to take care of these patients now.
Julie's so right, Cassie. You know, the number of people waiting in our emergency rooms for care has skyrocketed the last couple of weeks. And we also received transfer lists of the patients that Julie's describing, and time is brain, and any delay with stroke or heart muscle makes a really dramatic difference in the outcome for our patients. And you see, as leaders in these hospitals and as nursing leaders in these hospitals, you see these lists of people that are wanting care from your place, and you have to make them wait. It's heartbreaking.
I think this really, one of the points we've made multiple times in these press briefings is for people to do everything they can to keep themselves out of the hospital. So stay off ladders, wear your bike helmets, take your cardiac medications, see your cardiologist if you have a heart condition, you know, be taking care of your blood pressure, all the things that help keep you healthy. So we really want to emphasize that to people, that they should be doing everything they can to keep themselves healthy. So Dr. Eckert, if you will round us out with a view from what you're seeing with pregnant women and newborns would be great.
Well, thank you so much, Cassie, for having me. I feel like one of the under messaged alarms right now is for pregnant women, pregnant patients. At the University of Washington, we have quite a few pregnant women who have COVID, and we've had several in the ICU. We've had to do many deliveries early because when a pregnant individual cannot maintain her oxygen level, then we need to go ahead and try to deliver the baby for the safety of the baby. And we are seeing more patients than we have at any other time during COVID. And it is really raising alarm as those of us who have spent our lives trying to care for pregnant individuals. So I appreciate the opportunity to get the word out about just how bad COVID is for pregnant individuals. I have three main messages. One is how dangerous COVID is. Number two, how safe the vaccine is. And number three, how well the vaccine works in pregnant individuals. As far as how dangerous COVID is for pregnant individuals, we're getting more and more data about this. And there was a recent study that looked at pregnant individuals from 500 hospitals across the country. over 800,000 pregnant individuals and looked at the pregnant individuals who had COVID versus those who did not. And I am seeing risks for the pregnant individuals that I've never seen with any other event in pregnancy. For instance, 15 times increased risk of death if you're pregnant and you have COVID compared to having COVID with you're not pregnant. 14 times increased risk of being on a ventilator. 22 times increased risk of early labor and needing to get delivered before 37 weeks, either because going into labor because you're ill or needing to get delivered to help protect your lungs. So we are, this is very serious and it's alarming for those of us who've been in the field and now are just watching this happen to our pregnant individuals. And as a response, I would say that the American College of Obstetrics and Gynecology, the Society for Maternal Fetal Medicine, societies in England, all over the world are absolutely behind vaccination of pregnant women with the COVID vaccines of pregnant individuals. And the reason is we're getting more and more data about the harms of COVID, but we're also getting more and more data about the safety of the vaccines. You know, as we all know, pregnant individuals were excluded from the trials, originally the phase 3 trials with these vaccines. And so we've relied on collecting data as we've gone forward and experience with pregnant individuals. We have a lot of data now. And we recently just published a study of over 17,000 pregnant individuals looking at their reactions to the vaccination and found actually that pregnant individuals did not react more severely to the vaccines. Actually, they actually had a fewer side effects than women who were not pregnant. But mostly the message there being that pregnant women tolerate the vaccines very well. We know how the vaccines work. We know they don't stay in the body. We know they don't cause changes permanently in DNA. We know there's not a risk of infertility. So we feel very comfortable with the safety of the vaccines. And that data is continuing to be tracked and monitored quite carefully. And we also just had a recent study out from the CDC showing there was not an increased risk of miscarriage if you got the vaccine early in your pregnancy. So again, we're getting more and more data about the safety of the vaccine. At the same time, we're getting more data about just how dangerous COVID is in pregnancy. And lastly, we're getting data that the vaccine works, that pregnant individuals do make antibodies. They do transfer their antibodies to the fetus via cord blood and then the breast milk once the baby has delivered. And so they can offer protection to their infants. And as we're seeing COVID become more and more a disease that's striking younger and younger individuals, I think it's a wonderful opportunity for a pregnant individual to consider offering protection to your newborn by getting the vaccine yourself. So not only are you protecting your newborn by keeping yourself healthy, you're protecting your newborn directly by transferring antibody to the newborn. And I guess my last plea would be that I know as a society, we have always chosen to value pregnant women, to view them as, it's just kind of a special time when you see people that they're pregnant. What we can do to help our pregnant population is get vaccinated. The Delta variant is much more infectious. It is hitting everybody harder. Just the message, the methods of protection like distancing and masking aren't working quite as well. I think they're still extremely valuable and need to be followed very carefully. But truthfully, if you want to protect pregnant women around you, get vaccinated. And if you're pregnant, get vaccinated.
Thank you, Dr. Eckert. Really appreciate that. And I think it's, I have 3 kids, and the kinds of things that Dr. Eckert is describing are the things that as a pregnant person you live in terror of. The fact that you might get really sick, need something like I can't imagine being pregnant on a ventilator or having your baby have to be delivered early and need neonatal intensive care unit treatment or dying. There's just it's hard to comprehend how shocking and terrible all those outcomes are and how they will have potentially multi-generational impacts on these kids.
And Cassie, I would just add that we've had to turn down transfers at the University of Washington to our ICU of pregnant individuals who need ICU care, and we just simply can't take them. That does not bode well for how they're going to do in their hospital that they're currently in, that feels like they need to go to a higher level of care to take care of them.
Thanks, Dr. Eckert. Also chilling. So really want to underscore that for pregnant women, for the health of themselves and their babies, so they can be their babies, their healthy babies' mama for years to come, and not be either a sick or debilitated mother, or have a baby that doesn't survive, or the mom doesn't survive. Okay, we're going to now turn to questions. And Hannah, with Q13, I think you had a question you wanted to ask over audio.
Yes, thanks for taking my question. I know that right now the Mu variant is not here, and we know that, and that's a good thing. But with that said, I wanted to ask someone here, a doctor or anyone really who wants to respond to this, how important is this going to be as far as vaccinations and fighting dangerous variants that may be coming our way? So I know we're talking about the Delta variant right now, and that's also important, but is the medical community concerned that if the vaccination rate is as low as it is, that this could fuel more dangerous variants that could escape vaccines in the future?
Dr. Eckert, you want to take that?
Yeah, I will take that. I would say, you know, I'm the American College of Liaison to the ACIP, and we had a meeting last week.
ACIP is the infection preventionists who are working on vaccinations and trying to control COVID throughout the country.
Right. Thank you for clarifying that. And so I feel like that's an active conversation piece. We absolutely know that where variants breed is in individuals who catch COVID, and that the individuals who catch COVID are much more likely individuals who are not vaccinated. So I think that the low vaccination rate can definitely contribute to future variants. And you know, after Mu could come another variant. So it is absolutely a idea of concern, and one that's being tracked carefully. And we 100% know that the more people who are vaccinated, the fewer hosts we have to have this virus mutate. So it's, you know, it is very much a community health. How do we preserve all of our ability to fight this disease? Tom Bonsi has his hand up. Tom, let's call on you.
Yeah, thanks for taking my question. I had a question maybe first for Peg, but perhaps for any of the others on the call about transfers between hospitals. Peg, you mentioned the North Idaho going now to rationing care. Are you in the Spokane area taking patients now from Idaho, their overflow? And to what extent can
thank you. Thank you for that question. And I think our entire Eastern Washington community has really responded to the call of help there. Kootenai has done a marvelous job on trying to manage their own. So I want to just say that first and foremost, but because they're so close, they're 40 minutes away from us, Tom. We do see some, but not all. And when I say I'm including Multicare as well as Providence here, because we're really kind of all in this together. The transfer list is a unique thing I'd like to kind of speak of a little bit more. And what's called the WMCC, which they are the state placement kind of committee that tries to help and coordinate all of us so we can try to get a patient somewhere that needs it the most. So they produce, as well as we get calls from surrounding communities or even outside of our state. I think my furthest one so far has been the Denver, Colorado area. That was kind of interesting. But in any event, we've had to initiate patient placement committees with physicians at our various hospitals to really assess and prioritize in conversation with these facilities that are wanting to transfer, to try to identify who's at the most risk for a higher level of care and what can be managed where they're at and what cannot be managed where they're at. One of the things that's striking me across the state is that concerns for staffing of dialysis patients, and that's hit us all everywhere. And not only for just hemodialysis, but for a very complex procedure that we do in our ICUs, that's CRRT, continuous renal. Doctor, you can help me with the rest of that, but it's a very complex procedure that we do for patients in the ICU to help get them well. And it's really been a challenge to try to prioritize. So in the overall spectrum of things, we are triaging care across the state right now.
And the question specifically about the Washington hospital's commitment to take patients from out of state, the hospital leaders have been meeting to discuss how transfers work across the state and how their commitments to each other. And the decision has been each individual hospital's decision whether or not they take an out-of-state patient, but that we have some special processes through the Washington Medical Coordination Center, and those only apply to patients that are in a Washington state hospital, that we are not sort of guaranteeing the help to anyone that's outside of Washington state. A follow-up question about could Washington be headed in the same direction of crisis standards of care? And will Idaho's crisis impact Washington hospitals? I think Idaho's crisis will impact Washington hospitals. I think it's going to be really hard for the hospitals in Spokane, even as full as they are, who have very strong relationships with the hospitals in Idaho, to say no, but they also want to preserve. I think, Peg, you can talk more about this. This feels like an incredible ethical conundrum that you're in about how do you respond to what's happening in Idaho, when we also know, and Idaho's vaccination rate's very low. They're not doing masking in schools. There a whole bunch of stuff is contributing to the crisis there. So I think it's challenging.
It really is challenging. And, I think when we look at trying to take care of the greater good, the best message that we can give people is that healthcare is not an unlimited resource. Care and concern for one another is what's going to convince people to get vaccinated. And, we have a lower percentage, even in Eastern Washington, Spokane and Stevens County, of vaccinations as well. But it's slowly climbing. And I think people are really realizing and seeing more of their friends and their neighbors and their family members get severely ill or even succumb to this horrible respiratory illness. So I'm hopeful, but we need to continue to make sure people understand that it's safe. As Dr. Eckert mentioned, it is safe now, and Pfizer's got full FDA approval, and we really just need to get over any kind of other issues that we have and look at the science and trust the experts. Nurses and physicians have been the most trusted profession ever, and people do trust them. So please, continue to get the messages out about the safety of vaccinations.
And then to the other question about could Washington be headed in the same direction, we are working as hard as we can to not get to crisis standards here. And also, people are not getting care that they need. That is like the colostomy reversal that I mentioned earlier, and the incredible, profound life impacts that would have. Again, not life-threatening. It's not crisis standards because it's not threatening someone's life. It's terrible. It should not be happening. So there's a real mix of what the impacts are right now.
Well, Cassie, and I would just mention that in some of the more rural regions, like the one that we exist in, we're standing up region-wide crisis triage teams. So we don't have, the volumes of physicians in a single facility to help answer the questions about crisis triage. So we're reaching out to multiple organizations for medical ethicists and physicians to help answer those questions. So I don't think it's much of a stretch to say that Washington hospitals, either collectively or individually, are going to find themselves asking and answering those kinds of questions.
We have a question about how are death rates looking today. They are on, I think I mentioned this at the beginning, I don't think the death rate data that's been reported over the weekend is going to be reliable yet. It probably will be this afternoon. So I would check the state's dashboard this afternoon because I think there's some reporting that because of the Labor Day holiday probably is not quite up to speed. But I don't know if Peg or Dr. Eckert or Julie, if you've seen any trends in deaths within your own facilities or if you have that data yet this morning.
No, I don't. Thank you.
I looked recently, Cassie, just in our own experience. So it's, not scientific for across the state by any means, but early on, because we had more elderly and because we were learning how to treat COVID, the death rates were higher. And our experience here in Providence and Eastern Washington was about 16% at the beginning of the pandemic. While our intensivists and our nurses have gotten more experience with how to care for these patients, particularly in the ICUs, we are seeing a decline. Yeah, so that's some good news, but it's still too high. It's between 9 and 10% right now here in our facilities here at Providence in Eastern Washington. Our hope is now that with this monoclonal antibody, with people that are diagnosed early, if they receive the infusion or the sub-Q services of that we'll be able to minimize the impact that the disease has. But this is still early. And Dr. Eckert, do you want to comment a little bit more on the monoclonal antibody?
Well, I can comment a little bit on it. I know that we are working to activate the ability to give it to our pregnant women as outpatients, and many centers around the country have. I cannot speak generally to the University of Washington where it's being offered. I mostly have the experience just with the labor and delivery suite.
Thank you. The other thing I would say about the death rate question is that what tends to happen is you see case rates go up and then you see hospitalizations go up. This is kind of a time stagger. Case rates go up, hospitalizations go up, number of ventilated patients go up, and then number of deaths go up. And so I would point out that we have a 34% increase in the number of ventilated patients since last week. So that is a shocking number. And some of them will make it, some of them won't. Everyone will be profoundly impacted by having been on a ventilator. As I said before, you don't get off a ventilator and just go right back to life. It is a hard recovery. Okay, this next question. I mentioned that hospitalizations over Labor Day weekend that we know of so far made a big jump. How did this compare to the nationwide numbers, which were more than double those of Labor Day 2020? I actually don't have the Labor Day 2020 Washington state numbers. I don't know, Beth, if you could see if that's findable on the state's COVID data dashboard. Our hospitalizations are really high. We're also not as bad as like Alabama, Texas, Mississippi. So I think we're probably better than those folks because we do have, we're, as we said before, very, very grateful for Governor Inslee's mask mandate for indoor settings, for school mask mandates. Those should be happening everywhere around the country. So that's kind of a vague answer. I don't know about how we are compared to where we were Labor Day 2020. Feel free to unmute yourself if you want to talk more about that. Another question of how much has come together with the monoclonal antibody treatment. Where is the state right now on getting that more widespread to pharmacies and doctors' offices? I think I would encourage you to contact the state with that question. We are part of the group that's working on this, but we're really, really interested in having standing orders for monoclonal antibodies that can be administered in many more places. That I don't know I just am not in the loop enough to know the current status of that. How often are hospital emergency rooms on divert these days? In other words, not accepting incoming ambulances for a few hours here and there, or for days at a time anywhere. Can each of you speak to your own experience being on divert and whether other hospitals in your communities are on divert regularly?
So I'll jump in from the rural perspective. So divert is a lot more nuanced now. So it used to be if a CCU was full, or if a cath lab was down, a hospital, one of our regional referral centers would be on divert for cardiac or something. Now you're still making that phone call, and you may actually come to a point where you're saying, well, we can take 2 of those med-surg patients from you. We've got this cardiac patient. We really want to get over there. So it's working with WMCC, again, as that statewide resource for us. But there's just a lot more nuance now to divert. I think if it were normal times, most of us would feel like we should be on divert. but we're working together and we're networking as hospitals to just extend the capacity as much as we possibly can by accepting patients we typically would not be accepting, and by working on transfers, getting in line and dialing sometimes a dozen hospitals looking for a bed.
Yeah, that was a beautiful answer. And we can't forget that we have our emergency medical response teams that are our partners too. And just to say we're not going to take patients when we're in a situation as we are today is just irresponsible. So Julie said it well, divert is not really what it used to be. And we just have to work with them, prioritize with them, and try to make the best decision for how we manage the patient in our communities as we can.
And I would just speak to that is that's true for pregnant individuals as well. Those decisions are made one-on-one via phone calls with the provider who wants to refer the patient in, and then checking with staffing, checking with the ability to meet the needs of the incoming patient versus advising the provider who wants to transfer about potentially how to manage the patient locally. So it's a very individual decision.
I think that I have gotten through all the questions. We have a few more minutes. If anybody has other questions they'd like to ask orally, please raise your hand. Tom, your hand's back up.
Yeah, if no one else wants to jump in, I wonder if I could hit the Idaho overflow question one more time. How far potentially could patients from Kootenai or Moscow or Sandpoint, Idaho be transferred into Washington State through WMCC?
So Cassie, do you want to explain WMCC one more time?
Yes, so the WMCC is the Washington Medical Coordination Center, which is based at Harborview, and its job is to find beds for patients that cannot be found a bed for either through the hospital's internal system. So, for example, like a Providence system might transfer patients within Providence, or through their normal transfer patterns. So, Kittitas, Julie, where do you normally what are your top two transfer places?
Virginia Mason and Yakima Memorial.
Okay, so if those two places were full, or or Julie then might call Confluence, or you might call Swedish Issaquah, you may keep calling down the road when they're full and you can't find when you've exhausted both those routes, your own internal process. And well, first of all, can you keep the patient? Can you transfer it within your system? Can you go through your normal transfer processes? When all those answers are no, then you turn to the WMCC to help find a place for patients to go. The hospital leaders in Washington State have committed to each other that at the moment, this could change because we don't know how bad the patient load will get, but at the moment, when the WMCC also can't find a place for a patient to go, feels like all hospitals are equally full, that the large hospitals will be on essentially a guaranteed acceptance system. WMCC will notify the hospital association this is needed, and then the hospitals will go into basically a rotation to take these patients. And as I said, this may not be a long-term commitment. It's a commitment for the moment as we're at the current surge where we are, but that commitment does not apply to out-of-state patients. So if someone from Idaho is needing a place and all the hospitals will equally full, the hospital leaders have not committed they will take out-of-state patients. It's to serve Washingtonians. Does that answer your question or not?
Well, I guess I would ask, are you having any experience yet of North Idaho patients being brought all the way to Seattle?
Oh yeah, that already happened before now.
But that already happens. Okay.
Yeah.
Yeah.
I think the requests to do that are probably greater. Dr. Eckert, are you getting more requests for pregnant women to come to the UW than you did a month ago from Idaho?
Yes.
Yeah. So it's been there throughout the pandemic and it's definitely accelerated.
Okay, thank you.
Another question is, crisis standards of care has been defined by some as rationing care. Is that really an accurate description? It is an accurate description. So the way that crisis standards could work is that it's the most, when people have thought about crisis standards the most, which is not the only time you would use it, but would be like an earthquake, where you have an earthquake and you've got 60 people who are severely injured who need trauma surgery, and you have capacity to do trauma surgery on 30 of them in the time frame that it's needed, and you determine which 30 has the best chance of survival. That is the kind of the classic definition of crisis standards. So it is, at this point, it could be, who receives a ventilator, who's got the best chance of survival. So I don't know exactly how Kootenai is working on crisis standards. In Washington State, we have a group of medical experts that's called the Disaster Medical Coordination Committee, the DMCC. You could definitely Google that. They've got a bunch of stuff on the web about what crisis standards looks like. It is something we very much do not want to have happen here. And it's the underpinnings of of what I just described in the Washington Medical Coordination Center, this mutual hospital commitment in Washington State, which we made more than a year ago, almost a year and a half ago, that no individual hospital would ever go into crisis standards. That would either be a region-wide, like it might be Western Washington or Eastern Washington, or a statewide, that we would work to balance the patients across the state so they're all going up like this. So you don't have one hospital going to crisis and other hospitals not. And that has happened in other states where you've got individual hospitals that have gone into crisis. That happened in New York, it happened in El Paso, it happened in a number of places in California. So that's something we do not want to have happen here. Crisis standards is typically something the state would declare because we have this statewide model. I don't know enough about what's happened in Idaho, if it was just the hospital declaring or the state's involved in the declaration. Peg, do you know?
They just put out a media release when we started this call, so I haven't read it, but I'm happy to send it over to you, Cassie.
But here, so there may be some different systems here than there are in Idaho, with the commitment that's made through the association to all work together as one system and to work with the state's disaster medical coordination committee to determine when crisis standards might be needed, and if so, what is the protocol for rationing care. And it's typically it's often symptom based, like your oxygen saturation is below this level and your kidney function is below this level, or you've had organ failure of other organs, or some kind of combination of that. I think Beth, is Taya on the call?
I believe she is.
So Taya Briley is our Executive Vice President and General Counsel, and has got some expertise in crisis standards. Taya, is there anything you would add? Oh, I don't know. I don't think she is any longer. She might have been earlier.
She's not currently on the call.
Okay, sorry about that. Let's see if there's anything. Anyone else want to add anything about crisis standards? Oh, thank you. Tom Bonsi put in the chat that the state of Idaho agency declared crisis standards of care at the request of Kootenai Health for North Idaho region. That's terrible. I mean, that is terrible that's had to happen in Idaho. It's our heart absolutely goes out to our partners and friends at Kootenai Health. It is a absolute gut-wrenching decision for anyone who works in healthcare to have to make. It is terrible. We do not want that to happen here. And the key to that not happening here is people to get vaccinated. That's what will stop it. Any other comments? I think, people, all those things, getting vaccinated, wearing your mask, socially distanced, avoid large events. Like, we've got to come together to preserve the healthcare system for everyone. We have got to. It is like what Julie described about people with strokes and heart attacks, what Dr. Eckert described about pregnant women not being able to get a higher level of care, for the lower level things like not being able to have your colostomy reversed. These are terrible outcomes for people in our state. We have got to do better. It is not, as Peg said so eloquently, this is not an unlimited resource. All right, with that impassioned plea, Nicole, your hand's up.
Hi, I was wondering, do you have any estimates? Has anyone died statewide, or do you have any estimates for how many people have died as a result of this unfortunate triage system where, as you said, stroke patients may not get care right away, or an appendectomy happen right away?
I don't have any estimates of that, but if you look all across the country and the world, you can see the excess deaths, and that's that's what that is. It's like, you know, you delayed care, you couldn't get the care as fast as you needed it, you were scared about going for care, all those things. If, you know, you take normal death rates, add COVID, and then excess deaths is all those people who are not getting the care that they need. Anyone else want to comment on that?
The Trauma and EMS Council has some good data, and it's a little bit dated because of the way this all kind of comes together. But in terms of other things that people don't think of is increase in suicide, increase in domestic violence, changes in other types of things that you wouldn't think of as an acute episode. They've got some really good data, and just maybe reach out to Dolly Fernandez and the Department of Health to access that data.
All right. Thank you all so much for joining us. We are going to be back, not next Monday. Our plan right now is to not be back next Monday, but to be back the Monday after that. I don't know the exact date of that. If things, we might decide that we need to do it sooner than that, but that is our plan. The Monday, the 20th would be the next plan that we would come together.
Thank you.
Thank you all very much. Thanks, Julie. Thanks, Dr. Eckert. Thanks, Peg, so much for your time. Take care, everybody. Get vaccinated, wear your masks.